Let me now invite Dr. Indika Kulasinghe, consultant rheumatologist of District General Hospital Gampaha, to talk on psoriatic arthritis, the rheumatological perspective of psoriasis. Over to you, madam.
Good morning. Thank you. I would like to thank both colleges for giving me this opportunity to talk to you on psoriatic arthritis. As you already heard, psoriasis is not merely a disease of skin or only the disease of joints, but it can affect a lot of systems and many organs. So I'm going to talk to you on the musculoskeletal involvement of psoriasis. That is psoriatic arthritis. Standard abbreviation is capital P, simple S, and capital A. So I would talk on these topics within next few minutes. I would spend more time on diagnosis and pharmacological management. It is categorized under the umbrella term of spondyloarthritis. It is one of the major disorders under the spondyloarthritis, which we consider it as a spondyloarthritis. So it can affect the axial skeleton, peripheral joints, tendons, and entheses. In addition to musculoskeletal system involvement, that can affect non-musculoskeletal, that can cause non-musculoskeletal manifestations as well. So cutaneous manifestations, you have already listened to that. Onychodystrophy, nail involvement, and gut involvement with inflammatory bowel disease, eye involvement with uveitis. So it is a heterogeneous disease with involvement of many organs, skin, nails, axial skeleton, peripheral joints, entheses. Yes. So let's move on to see how the manifestation of arthritis in psoriasis. 30%, as Dr. Akaravita said in local data, this is the Western world data, 30% of patients with psoriasis get psoriatic arthritis. People who are getting nail involvement, they are more common to get arthritis. So if you get a patient with nail involvement, even though they don't come up with complaint with joint pain, it's better to monitor them for arthritis. That this arthritis can appear with the skin manifestations, after the skin manifestations, and before the skin manifestations. So it is very important, if you are having a patient who is having arthritis, very suggestive of psoriatic arthritis, look for skin manifestations as well. Sometimes these patients are harboring skin manifestations in hidden places like natal cleft. The patient is also not aware that they are having psoriasis, so they don't come up with the history. Other than the musculoskeletal involvement, it can have other comorbidities like cardiovascular disease. They are more prone for ischemic heart disease-like conditions. These patients are having disruption in their psychosocial relationships, so they are prone for depression-like things, and they are getting metabolic syndrome commoner than the normal population. As in any other disease, the diagnosis of psoriatic arthritis, history is very important. First, you have to ask and see whether the patient is really having an inflammatory type of arthritis that gets worsened with rest, and it will improve with more movements. So such things, and personal history of psoriasis, family history of psoriasis, how their day-to-day activities are affected with psoriasis, such things are important in the management of these patients. So those things should be taken in the history. And in examination, it is well known that skin should be examined, and nails, In addition, musculoskeletal examination, there's no way out. You have to examine each and every joint, axial skeleton, peripheral joints, tendons, enthesetic points, all those things you have to examine. Otherwise, sometimes patients are not telling that they are having Achilles pain in the Achilles tendon. When you are examining only, they will say they are having a tenderness. So they are having, you can elicit the tenderness. So then the examination is very important in these patients. With good history and thorough examination, you move on to targeted investigations. Not just investigations, it should be targeted investigations. ESR, CRP like inflammatory markers will be high in these patients, but it is not always. 50% of these patients can have normal ESR and CRP. Full blood count, there can be changes of chronic disease like normochromic normocytic anemia, high platelet count, and negative rheumatoid factor is a 4-factor for diagnosis of psoriatic arthritis. Liver functions, renal functions are important as far as the management is concerned, because most of our drugs can affect liver functions and renal functions. So you should have baseline values. Imaging is important in diagnosis of these patients, because sometimes you are not sure whether these patients are having synovitis or inflammation of the joint, or whether they are having just subcutaneous swelling. So in such instances, not always, sometimes you can detect arthritis very well with examination, but whenever you are not sure about the thing, you need to do this imaging. Ultrasound scan, which is freely available and gives us good information regarding the inflammation of the joints. MRI is also giving similar information, but there's a limitation. The availability is limited. X-rays, you can do X-rays. There can be changes in the X-rays, but by the time you get X-ray changes, it will be very much delayed, because we need to modify the disease process with our treatment. By the time you get X-ray changes, it may be very late to start disease modification. So before the patient getting symptoms of joints, you can detect with ultrasound scan nowadays. So ultrasound scan is complementary to clinical examination. In ultrasound scan, you can detect synovitis. According to the gray scale, you can detect synovitis. The stars are showing synovial thickening in the metacarpophalangeal joint in the extensor aspect, and there's power Doppler enhanced signaling in the right side picture, and metacarpophalangeal joint on the flexor aspect, you can see the stars denoting the peritendinous edema, and on the right again power Doppler signaling, high signaling of power Doppler. With this information, you can detect whether the patient is having arthritis or the synovitis, tendinitis, or enthesitis really. You can detect the thickening of the tendon by measuring the tendon thickness as well. So there's a Kobner phenomena we are talking about in psoriasis. This enthesitis and deep Kobner phenomenon is seen in this enthesetic points, so we can get a good idea about this deep Kobner phenomenon with this ultrasound scan studies. Dactylitis, it is a characteristic finding in psoriatic arthritis. It will have a swelling of the subcutaneous tissue, peritendinous tissue, and the synovium. The whole finger or the toe will get inflamed, and it will appear as a sausage. That is not just involving joint, but the whole finger or the toe is involved. So you can, with ultrasound, in that case also, we can get a good idea about dactylitis. We have CASPA criteria for as a classification criteria for psoriatic arthritis. I would emphasize the fact that this is not a diagnostic criteria. This is a classification criteria to select a homogeneous cohort of patients who are having psoriatic arthritis as far as the study purposes. So the concern. So this helps us in the clinical setup what to look for when coming into a diagnosis. But we need not to wait until the patient fulfill all the criteria according to the CASPA classification criteria to diagnose psoriatic arthritis. So, but we can get a help, and this will remind us what to look for when we are arriving at diagnosis. So I will move on to management of these patients. There are two types of management we are talking about as in any other disease, non-pharmacological and pharmacological management. As you know, non-pharmacological management includes physical therapy, physiotherapy, occupational therapy. Physiotherapy is very important because this is a disabling, disfiguring, deforming arthritis. So you have to maintain the joint mobility, muscle power, and strengthen the surrounding muscles. So for all those things, physiotherapy is important. Occupational therapists are dealing with training of activities of daily living and hand functions. So this is a disease, as I said earlier, which can cause disruption in their day-to-day activities. So the occupational therapists can help them to get their things done with the deformities if they develop, and to prevent the deformities if they are not still having deformities. And hand functions also trained by occupational therapists. Smoking is bad for any disease, and all the inflammatory arthritis get worsened with smoking. So it is very important to advise them to stop smoking if they are having psoriatic arthritis. Weight reduction, because I spoke about this Kobner phenomenon with these mechanical forces, they can get damage to the deep structure, especially lower limb joints and enthesetic points. So it is important to have reduction in weight. Exercises, again, important in maintaining joint mobility, improving muscle power. Pharmacological management, we are talking about pharmacological management to modify the disease, to relieve the symptoms, and to achieve a target. So to modify the disease, you have to attack specific targets in these patients' disease process. So I have to talk about immunopathology in these patients before starting this pharmacological management. So as I have shown in the this slide, there are cytokines, tumor necrosis factor inhibitors, IL-12, 23, and IL-17, like cytokines, will take part in immunopathology. Initially, with triggers, the peripheral dendritic cells get stimulated, and they in turn produce cytokines to stimulate the central dendritic cells, then all these cascade activates with immunopathology cascade activated. This is pathogenesis of, in a very simplified manner, skin involvement with IL-23 activation by dendritic cells. So let's see how we manage these patients. There are few academic organizations giving us guidelines in managing these patients. EULA guidelines, I'm going to talk about this EULA 2019 update next. ACR's American College of Rheumatologists and GRAPPA, these are the academic organizations giving us guidelines. So EULA 2019 update, according to that, first we have to do a clinical diagnosis. It should be a clinical diagnosis where you have to get a good history, do a clinical examination and clinical diagnosis. On the basis of that, we can go ahead with management. If the patient is having polyarthritis, that is more than 4 joints involvement, then you can straight away go to conventional synthetic disease modifying drugs like methotrexate, leflunomide, sulfasalazine. But preferably methotrexate. If the patient cannot tolerate, only we go for other conventional synthetic disease modifying drugs. If patient is having monoarthritis or oligoarthritis, less than 4 joint involvement, then we can start non-steroidal anti-inflammatory drugs and local steroid injections like joint injections and enthesetic points. You can give local steroid injections. Systemic steroid, we have to be very careful when we are giving. Sometimes we have to, but we have to be very careful with the tailing off of our steroids. The skin manifestations can get worsened. So if the patient improves with NSAIDs and local steroid injections, you can continue with that time to time whenever the patient gets symptoms. But if the patient is having poor prognostic signs like high inflammatory markers like ESR, CRP elevation, radiographic damage, dactylitis, nail changes, those are bad prognostic features like high disease activity. So then you have to move on to conventional synthetic disease modifying drugs. Then if the patient is having enthesitis or if the patient is having predominantly axial skeleton involvement, then we can try NSAIDs and local steroids again. But if the patient is not responding, we have to straight away move on to the phase 3 where you give biologics. If the patient is having peripheral arthritis, then we can give tumor necrosis factor inhibitors, IL-17, or if that is not appropriate, we can move on to Janus kinase inhibitors, JAK inhibitors. But in axial skeletal involvement, we can give biological DMARDs such as tumor necrosis factor inhibitors, IL-17 inhibitors. If they are not responding to these drugs, we can change the drug in the same group or between groups. Like that, we have to change our treatment according to the guideline. This is how we have to manage. But in a country like ours, we can't totally go by this Western population giving guidelines. So we have to modify our management according to our available facilities. So the biologics are evolving very fastly. Before the new millennium, we had infliximab for this psoriatic arthritis, etanercept, adalimumab, golimumab, certolizumab, like tumor necrosis factor inhibitors are available now. And in addition, there are new drugs, ustekinumab, secukinumab, as Dr. Akravita said. So there are some more drugs in the pipeline. The next few years to years, they'll be come for our guidelines. And I would, these biologics, when you are selecting biologics, you have to know which drug should be given to which patient. So if the patient is having mainly enthesitis and exoskeleton involvement, as I said earlier, they can be given some drugs like ustekinumab, and IL-17 inhibitors, secukinumab. Then whenever the patients are having skin involvement, that is different. So you should know the pathophysiology, immunopathology of this disease in related to drug activity. As I said, tumor necrosis factor inhibitors, IL-12/23 inhibitors, IL-17 inhibitors, they can involve with whenever the patient are having mainly skin involvement, you can give IL-12/23 inhibitors. Whenever the patient is having mainly joint involvement, IL-17 inhibitors, and tumor necrosis factor will cover all these things. And these are new drugs which act on this disease process. Ustekinumab inhibit P40 moiety, which contain in IL-12 and 23, so it inhibit IL-12, 23, both cytokines, and secukinumab IL-17 inhibitor will inhibit IL-17 cytokine, and brodalumab, which is available for registration, it will inhibit IL-17 receptor. So targeted synthetic DMARs, Janus kinase inhibitors, phosphodiesterase 4 inhibitors are there, because now until up to DAC inhibitors, we were handling the extracellular cytokines, and JAK pathway and the phosphodiesterase pathways are the two main hubs which these extracellular cytokines act on the immune cell. So if we can inhibit these two pathways, JAK and phosphodiesterase 4, then we can stop most of these cytokines acting on our immune cell. So in summary, disease-modifying drugs, there are conventional drugs, new biologics, and JAK inhibitors are the latest ones. And even though we have a lot of these modern drugs, we have unmet needs in psoriatic arthritis. So we don't have a biomarker to diagnose psoriatic arthritis like rheumatoid factor and ECPA in rheumatoid arthritis. We need a way to prevent psoriatic patients getting psoriatic arthritis. That is also a requirement if possible. So in summary, clinical diagnosis, as soon as you get the patient, early diagnosis will enable us to do a good disease modification. This needs multidisciplinary approach in managing the patient. Increased understanding of these patients' pathogenesis allow us to produce better drugs. Thank you.